for you. If people in the United States are asked the question, where would you like to die, what do you think their response is? At home. Overwhelmingly, people say they want to die at home. Yet, very few people in the United States at this point, really about only a third of people who are 65 and over Medicare recipients dying at home. So there's still a real disconnect between what people really want at the end of life and what they're receiving. According to the Kaiser Family Foundation, which did an extensive study in 2015 on end-of-life issues, when asked, over 90% of the adults that were asked said they wanted to die at home. And again, only a third are having that wish honored. So we really strive to get the information out there for people to know that they have options. And when we talk about dying at home, home can be a lot of different things to a lot of different people. It could be the home that you raised your children in. It could be your son's or daughter's home. It could be a continuing care retirement community where you think from independent living to personal care or assisted living or to skilled nursing. Basically, what people were saying was what they don't want, and that is they don't want the institutionalized surroundings of a hospital to die. So they really, really don't want that. And as Jim mentioned, as of January of 2016, Medicare now reimburses physicians for having end-of-life discussions with their Medicare recipients. So it could be part of a wellness visit, or it could take place in the doctor's office. It could take place in a facility like a hospital or a skilled nursing facility. But it needs to take place. And again, this Kaiser Foundation survey found that 89% of the respondents felt this was a wonderful idea to have end-of-life discussions with physicians. However, out of that 89%, only 17 have even had any type of conversation with a physician about end-of-life issues, right? So, and we all know that. But look at us. I mean, it's never too early to have that conversation. At this point in our life, we should be letting those that know us and love us the best know what it is that we want at the end of life. Hospice is a tremendous benefit. It is an underutilized benefit. Again, as Jen was mentioning, you've worked your whole life to be eligible for this benefit, yet so few people access it. Although it's good news that more and more people are accessing it. But when they do, it's so often very late in the process, so they don't get the full benefit of hospice. If you sign on early, if you get on to hospice early when you're eligible for the services, you get that connection, you make those connections, the social workers, the chaplain, the caregivers, the case managers. It makes the whole process so much more fulfilling. And if you think about your life as a novel, a great American novel, and you've written every chapter of that book, why would we leave the last chapter, which may be, in many cases, the most relevant and important chapter, we leave that out to somebody else because we don't have those conversations. So we can't impress upon you enough to get that dialogue going, find a way to initiate that conversation. It's essential. In Chester County, there's probably 60 hospices that can provide care here. So a lot of people will say, holy smokes, there's probably a handful that are the most well known. But it's so important for you, if you should come to a point where a loved one is thinking or considering hospice, or you've been approached by a physician that this might be the time to consider hospice, to do your homework. Not all hospices are the same. Some are very large corporate hospices, some are smaller hospices. The core services under Medicare look very similar, but there's tremendous differences on complementary services, whether it's healing touch or pet therapy, music therapy, all sorts of supportive services that can come in and provide care. So you need to ask those questions, do your research. And the other thing I want to leave you with is that you have a choice. Okay, I said there's probably 60 hospices, but what people don't understand is that you have a choice of hospice. A lot of times, the hospice referral is coming from a hospitalization. All of the hospitals in Chester County have their own affiliated hospice, so many times you're connected to that hospice before as you're leaving, you're connected to that hospice, not even knowing that you had a choice. So please, interview at least 2 or 3 hospices. Be, an informed consumer. If you should sign on to a hospice and you're not happy with that service, you can sign off and sign on to another hospice the next day, so you're not tied into that hospice forever. So I'm going to let Jen take over. Jenna Donatone is she's a nurse educator, so she does a lot of education in the community about the benefit of hospice. She'll describe what it is and hopefully we can answer some questions after. Jenna?
Hi everybody, I'm Jenna. I'm going to go through general hospice overview with some specifics. We'll get a little bit medical towards the end of the presentation. There is some medical jargon in here that I'll explain as we go. Like I said, it's general hospice information. We do have more specific information on Willow Tree that if you want that information at the end, I'm happy to give you that packet of information. Sally's our administrator and she has those packets. So just to start, hospice is really a concept. It's a concept that focuses on comfort. We look at treating our patients and their families with compassionate care, comfort being the focus. Not all hospice situations are the same. Anyone going through any kind of disease process never has the same experience start to finish. And it's the same with hospice. It's a very patient-centered, family-centered service. We try to coordinate the care to focus on whatever the needs and desires are of that patient and family until the end of their life. It emphasizes dignity and quality of life, which is very important, especially with elderly folks that are losing a lot of their independence. Some of it happens gradually, some of it a little more sudden, but we believe in affording people their dignity and independence for as long as we can, safely and comfortably for them. We focus on care rather than cure, so any type of aggressive type measures, treatments, don't really fit into the hospice concept, but it's never without discussion, without research, and really talking at length with families and their loved ones about what road to take when it comes to certain therapies and treatments. We focus on pain management, symptom control, emotional support, including spiritual support. There's a large team of people that help each one of our patients and families down this amazing road to the end of their life. Like I said, we care for patients and their families. I mean, caregivers, when you're providing the care for someone at the end of their life, and you're the primary contact, and you're the person providing the care and coordinating the care, and that person could be the patient themselves, but we look at it as an approach to just a group. It's our team helping that patient and whoever they want involved in the process. So our team is comprised of people who treat the physical, emotional, and spiritual side of things. We are open to all different kinds of therapies and modalities, whether it's medical or non-medical. So we focus on care that provides palliative rather than cure-oriented therapies. And palliative really is just another word for comfort. We provide therapies that are appropriate when there is agreement by the patient, family, physician, and hospice team. So like I mentioned, we want to keep everybody on the same page. It can get a little complicated sometimes when there's too many opinions maybe. Advanced directives are so important because they can clarify things when it comes to decision making. Unfortunately, like these guys all said, advanced directives aren't always in place, and I think it's 20% of our elderly population actually have advanced directives, and then even fewer of those people have family members that even know that they have an advanced directive. So to have one is great, but if you have an advanced directive and then you become cognitively impaired and can't communicate to anyone who actually have that in place, what's the point of having it? So, communicating that to the families is so important. Hospice care is provided in the home, like Beth mentioned, and the home can look like many different things. We go to lots of different kinds of homes. We've been to cabins out in the woods. We've been to every environment you could ever imagine. If someone wants to sign on with us and they want our care, then we're willing to give it to them, no matter what that looks like, no matter what their environment is like. So it can be a private home, it can be the home of a family member, assisted living, skilled nursing facilities, and then respite services is to provide a break for caregivers. So there are facilities in the area that will house the patient for a chunk of time so that the caregiver can have a respite break, because caregiving, especially for someone at the end of life, can be very stressful and tiring. So we recognize, and Medicare thankfully recognizes the need for respite in hospice. So, since you guys are all experts on Medicare, next to Jim, maybe tell me about this slide. No, Medicare covers hospice services. Everything is up for debate. The key is making sure that the patient is getting the therapies, medications, things that is making them comfortable at the end of their life. So it's not very black and white, and it all requires a discussion with the medical team and the family. The last thing anybody wants to do is commit fraud, Medicare fraud, but we don't let that happen. We would never, afford someone a therapy or modality that wasn't going to be covered by Medicare. But that being said, these are things that are covered: nursing services, social work services, counseling services, including bereavement, dietary and spiritual counseling, volunteer services, and then services provided by our medical director. There's an addition to this. When someone signs on to hospice, they can keep their own attending physician. So that physician writes an order to start hospice services, let's say. That doesn't mean that that patient has to use only our medical director from there. They keep their own attending physician, and then our medical director is kind of an added expert on hospice care, and we all, collaborate and work together. So these are some more covered services through Medicare. Our nurses' aides come into the home and provide personal care, whatever the needs are of the patient at that time, and those needs can change as things progress. So through Willow Tree, we provide an extended from 1 to 2 hour chunk of time daily with a certified nursing assistant, and during that time, there's a wide range of things that they can do to help the patient and their family. It can be as detailed as skin care, bathing, or it can be something more general, like things around the house, and it all depends on the plan of care that we come up with as a team. Medicare will also cover physical and occupational therapy, speech and language pathology services, and this is all, again, after decisions have been made by the team if those things are appropriate. That's the key, whether or not they're appropriate. And we never try to talk anybody in or out of anything, but we do want to be frank about what's appropriate for someone's treatment plan. There are outpatient medications, there are medical supplies, durable medical equipment, and oxygen, and then all diagnostic and therapeutic modalities. So who is eligible for hospice services? Any patient, this gets a little, a little more specific. Any patient who's eligible for Medicare, like Jim said, is eligible to elect the Medicare hospice benefit if they meet certain criteria. The first is that they have to have Medicare Part A, as he explained with our ABCs. That A is the hospice benefit. That's where that's covered. The patient must be certified by physician to have a prognosis of 6 months or less if their disease runs its usual course. That being said, many of our patients are on with us for way longer than 6 months. So today, as of today, if that patient seems like they may have 6 months or less to live according to their physician, then that's when they say, you know what, let's talk to hospice. Traditionally, hospice has been utilized way too late in the process, and thankfully lately that has changed. People are starting to elect hospice at a more appropriate timeline so that they can benefit from the modalities and the treatments and the symptom management rather than waiting so long until it's kind of a scramble to get things under control at that crucial time in the life. So considering what you may see with your loved ones, or what the physician may see, or what caregivers may see, when it comes to when hospice is appropriate, when it might be time to start talking about getting hospice involved. Now, it doesn't have to be any of these in particular or singled out. It can be a combination of these things, but we'll just go through each one. Sudden or progressive weight loss. That kind of goes in conjunction with the inability or unwillingness to take foods or fluids by mouth. Because weight loss isn't always associated with food. There are lots of disease processes that can happen that create, make someone lose weight, whether they're eating or not. So the weight loss is kind of its own separate thing. A decline in function, as far as being able to walk, talk, take care of themselves, toilet themselves, dress, anything that is kind of has a decrease that you notice. A cancer diagnosis without aggressive treatment. A decrease in the level of consciousness or orientation. So this would be like a cognitive decline. It can be on its own without anything else physically going on, which would be, as a result of diseases like Alzheimer's or dementia, or can be in conjunction with another comorbidity that also causes a decline cognitively. Increased pain and decreased ability to control pain. That's a big one when all the pain therapies just aren't really working anymore, and it's time to talk about getting symptoms managed appropriately. A progression of a disease to the level that heroic or, aggressive type measures are being considered to sustain life. So, someone being hospitalized, and the only way that they'll be able to sustain their life is being intubated or having assistance in breathing. We talked about the food to fluid, and then if the family or the patient expresses wishes for palliative measures only, or this DNR, DNH, DNI, which is, I apologize, it's very hospice jargon, but DNR is do not resuscitate, DNH is do not hospitalize, and DNI is do not intubate. And you can have any combination of those things when it comes to electing hospice. Some other parameters are an increased disease symptoms and non-cancer diagnosis. And here's some more specific examples, and this is where we get a little bit of medical jargon going. So I'll explain as we go. So heart disease, increased episodes of CHF. CHF is congestive heart failure, and that has to do with the cardiovascular system not being able to adjust fluids appropriately within the body. And syncope, which would be losing consciousness. We call them syncopal episodes, and that has a lot to do with the cardiovascular system, with the blood pressure and heart rate and things like that. The pulmonary, which is the lungs. So if someone has disabling dyspnea, it's a tongue twister. Dyspnea is difficulty breathing. So if someone is having enough trouble breathing that it's affecting their day, and they need to have rescue inhalers or rescue nebulizer treatments, or use supplemental oxygen, or even just sit down to recover from walking from the bedroom to the bathroom. If they've increased lung infections or low levels of oxygen at rest in the blood. These are all parameters to think about. When it comes to dementia, some of the parameters are the inability to ambulate, which is walking around, inability to dress themselves, bathe themselves, communicate, control their bowel or bladder, and dysphagia is the inability to swallow or difficulty swallowing. Difficulty swallowing is a common thing with dementia because it affects a certain part of the brain that first creates a disinterest in food and drink, and then also makes it difficult for people to swallow just neurologically. And then stroke symptoms are similar to the dementia ones. And then renal is the kidneys, and so if a patient has renal failure and decides not to seek dialysis, or has these lab values that are starting to point in the direction of a renal failure situation, and they decide not to go through any aggressive treatment for that. Some other non-cancer diagnosis are liver failure, HIV, MS, ALS, and Parkinson's. So this is a big question, right? So when is the right time to start talking about hospice? When is the right time to talk to your loved one or your family or your doctor? I mean, it's, like I said in the beginning, it's a case-by-case basis. It's not the same for everybody. You start to see some of these things that we listed on the last couple slides, you start to see a progression towards those things. It's always good to have an open discussion with your loved one, with your family members. It's really important for everyone to be on the same page, or at least close to the same page, because at the end of someone's life, emotions are at a maximum. And so decision-making can really be skewed by emotions and our own biases and what we want for ourselves rather than what we think might be right for our loved ones. So having that really frank, open discussion with our family members, with our care team, physicians, is really important. But to get more specific, the limited life expectancy of 6 months or less, there's nothing wrong with asking the doctor, what do you think about this? I've noticed these things going on with my mom. How do you feel about this? I mean, physicians they tend to go towards cure, and rightfully so. That's how they've been trained. That's kind of the way their brains work. Generally speaking, they tend not to just go towards hospice sometimes without having a discussion. And so as an advocate for your loved ones, and if you're a caregiver, it's always a good idea to bring that up. Just to put the idea in someone's head that that's something you might be considering.
Questions that you want to pass, my board will come up the center aisle on both side aisles.